Welcome to Accelero Health Partners Hip Fracture Audiocast. In the next several minutes, we will be highlighting key process improvements to help improve the care and outcome for hip fracture patients. Our focus today will be on the front end of the episode of care. First, we will discuss medically preparing the patient for surgery, then move into pain management, and then finally finish up with patient and family education. Hip fractures are unplanned admissions. No one wakes up and expects to break their hip, but unfortunately more than 260,000 Americans do that each year. Once they are admitted, the biggest challenge can be medically preparing that patient for surgery. And we know that the evidence tells us that delays in surgery, really, for any reason, can increase the chance for a less than optimal long-term outcome. Jenna, let's begin the discussion by talking about the optimal process for medically preparing a patient for surgery.
Well, first of all, the medical clearance process can look very different at hospitals. It can be led by a geriatrician or a hospitalist or even the surgeon, depending on the providers available at the program at that hospital. And then also with that program, what is their vision and goals for taking care of those patients? Ideally, the hospital should have a plan to co-manage this patient population because you really are dealing with two very pressing and important problems. The first one is fixing the fracture, and then the second one is medically optimizing that patient to survive the surgery to fix the fracture.
All right, so why is it so important to get the patient to the OR as soon as possible?
Well, really, when you think about it, the longer the patient waits for surgery, the more they decline. This patient already is generally inactive, and so now they are bedridden. They generally have a catheter in, they're on significant pain medications, they're not eating, and now they're in an unusual environment. All of these factors really help contribute to delirium, to bed sores, infections, and a whole host of other cascading health problems. In general, the goal should be to get that patient to the OR as early and as safely as possible. The providers will have more time to work them up medically once that patient is out of surgery and up on the nursing unit. When we look at our data within our business intelligence tool, OrthoVal, we can see that the complication rate for even our best performers jumps from 5.9% to 7.8% when the patient has surgery within 48 hours versus 24 hours. And that's a 30% increase.
That's a significant increase. What should these programs be concentrating on when optimizing their patients before surgery?
Usually, if you concentrate around 5 big buckets, it's best. First is cardiac disease, so looking at currently existing and known cardiac disease and working to optimize that. Secondly, pulmonary disease, same thing, current existing pulmonary problems. Third is endocrine disease, especially issues with diabetes, same that you would do to work that patient up if they were an elective patient. Fourth, working to reverse any coagulation issues. So if that patient is already on anticoagulations, what are you doing to reverse that so that they're safe for surgery? And then lastly, and this can be something that some hospitals neglect to work on, is looking at their nutritional status and hydration status, because these patients generally come in malnourished and dehydrated, so it's best to work them up as good as possible so they're ready to survive surgery and thrive afterwards.
Okay, let's switch topics now and talk about pain management. One of the biggest factors in how a patient rates a program is how well their pain was managed, both preoperatively as well as after surgery. So Jenna, pain management for the elderly hip fracture patient can be very complicated for a number of different reasons. Their age, the fact that they might have multiple comorbidities and polypharmacy issues. It can also be complicated by the fact that they could have been down for a while after their fall. What are some of the things to be aware of when the patient first comes into the ED?
You're absolutely right that these patients are very complicated. Of course, a primary goal for this patient population is to decrease their pain as soon as possible, but it's also very important to get some baseline assessments for these patients. Assessing the patient for confusion or delirium is essential because we all know that when you add medication to their systems, especially narcotic medications, it's only going to exacerbate the patient's situation that they're already dealing with.
All right, so we talked about early assessments being crucial. What else should you be concerned with when the patient is in the ED?
Really, you should be looking at and understanding 3 things. The first is what medications is that patient taking? 2, what comorbidities does that patient have? And then 3, like I said before, how malnourished or dehydrated that patient is. Because all of these things can have an effect on how that patient reacts to medications in general, but specifically pain medications. The assessments need to be completed as soon as possible so you get a good understanding of their baseline. And also, when you're looking after you're onboarding those pain medications, doing regular follow-up checks to check their respiration rates and mental status so that you are aware of what's happening with that patient.
I know the American Academy of Orthopedic Surgeons published a set of evidence-based clinical practice guidelines back in 2014. One of the big areas that they focused on was the fact that a multimodal pain approach is most effective. Can you talk about that?
Yeah, generally these patients are not used to taking opioids. So if your hospital has an opioid naive or a high-risk elderly pain protocol already, it's great to embed that into your hip fracture order set. If not, really understanding that a multimodal approach is trying to avoid those narcotic medications. So looking at acetaminophen, gabapentin, or pregabalin, or Toradol. And then also looking at different relaxation techniques. In that guideline that you referenced from AAOS, they do recommend starting regional anesthesia in the ER. So using a fascia iliaca compartment or femoral nerve compartment blockade to help decrease that patient's pain without increasing the patient's risk for delirium or nausea and vomiting.
All right, we've discussed medical preparation and pain management. The last topic is education. We know that when a loved one falls, it's a very stressful time. A common scenario is a loved one falls, the ambulance takes them to the hospital, and now they need surgery. Jenna, what's the most effective way to get everyone on the same page as far as what's going to happen next?
When we work with programs, we're always recommending to start that education process, and this means inclusive of the patient and the family during the admission process. You're able to set expectations before surgery so that you can help calm fears and help prepare everyone for what's going to come next.
It's really true. I've spent time in the emergency department and have experienced firsthand how chaotic and noisy it can be. Our experience has taught us that one-on-one education with a patient and the family is the most effective way to deliver. You want everyone involved to understand what's going to happen in surgery, when they're out in the unit, and after discharge. Jenna, talk a little bit about discharge. Based on our data, we know that most of these patients won't be going home after their hospital stay.
That's absolutely true. Our data indicates that a majority of patients are either discharged to a skilled nursing facility or a rehab facility after their time in the hospital. And it's because of that fact that it's important to start that discharge process, that education of the discharge process early while the patient's in the ER and then while the patient is up on the unit with themselves and their family.
It sounds like there's a lot of coordination that needs to happen, and I like the idea of having someone coordinating care for this patient population. Talk about a fracture coordinator and what that person could do.
So that fracture coordinator could be similar to what people experience as a joint coordinator. And when we're working with hospitals, we generally recommend that the hospital look at volume trends when they're justifying creating that position. In programs with moderate joint and fracture volume, generally that joint coordinator can be shared between both patient populations. And actually, Michelle Bianco and Luann Waldron discussed the role of a coordinator in greater detail during their post-surgical hip fracture audiocast.
Thanks, Jenna. This concludes today's discussion. If you have any additional questions regarding this topic or others, please reach out to your local Zimmer sales team member, and they can facilitate a discussion with Jenna or any other team member within Accelero. You can also reach us on our website at www.accelerohealth.com and then go to the Contact Us section. Thank you for your interest in Accelero Health Partners.